I am pleased to welcome you to our October seminar, and I'm glad that you can join us today for our online presentation. Just a few housekeeping items to review before we get started. Our program today will last about 60 minutes, and we will have a brief Q&A session at the end. If you have any questions for Dr. Urbiat, make sure your computer, microphone, or phones are muted at all times as we are recording this seminar. If you have a question, please use the chat feature in the bottom right corner of the Zoom page, and we will get to those questions at the end. The recorded seminar will be posted on our YouTube channel to view later. Additionally, I'd like to take a moment to thank our program sponsors, SK Life Science and UCB. Their generous support has helped us underwrite the costs of hosting today's program. Please visit our sponsors' websites or contact the local rep directly, and this information will be shared in a post-seminar email. Now, I am honored to introduce today's speaker, Dr. Ebru Urbiat of Metro Health. Her seminar is on the epilepsy in the elderly population, which I'm excited about because working with the elderly is something that I've done in my career, and that's definitely one of my focuses going forward. So I was excited to hear that, Dr. Urbiat, that you were presenting. There's a lot of important information I think that sometimes gets missed in the geriatric population. At that point, I would like to turn over to Dr. Urbiat, and she's going to present on this topic.
Thank you very much, Lisa. Thank you very much for everybody, especially Epilepsy Association. I'm very happy to get this opportunity. It's a very important topic, as you know. So during this lecture, I try to give the definition and then incidence and prevalence for new onset epilepsy in elderly population. And we are going to talk about some diagnostic challenges and differential diagnosis, which are very important, you will see. And etiopathogenesis, and obviously at the end, we're going to talk about the management of epilepsy. So when we start with the definition of elderly, there is, we can divide the population based on the ages, but investigators realize that division with the age is not going to be enough and meaningful to dichotomize this population, because some of the individuals might be very old but perfectly healthy, and some of the individuals would be young, old, maybe 60s, but they may have multiple medical problems. They may be very fragile or frail. So therefore, there's a proposed division after the 2003 consortium in the United States, and they were decided this kind of subdivision, and then this definition was later on introduced to the society. So after these definition, the investigators came across interesting findings, because most of the elderly population may reside in nursing homes, and they, when they looked at their population, they found interesting result that 10% of the nursing home residents are on the anti-epileptic medication, but most of them, majority of them, were placed on these medications at the time of the admission, and most of the patients using anti-epileptic medications were actually younger population rather than the older population, which was a little bit interesting because epilepsy increases by age we're going to talk about, and we're going to come back to that puzzling result. So we I already said that the epilepsy increases by age. We know that the older studies showed the epilepsy has bimodal graphic for their prevalence and incidence, where we see the higher incident rate in early life up to maybe uh, uh, 10 years, 15 years, and then the graphic shows plateau, and then the incidence would be increased gradually after 55, 60 years of age. And this is very important, and why this topic is actually interesting and needs to be considered. And as a matter of fact, we know epilepsy is the second most common neurological disorder worldwide in terms of the disability adjusted life years. And therefore, after 60 years of age, it's even more important. Uh, there are several studies uh, uh, how these age group and new onset epilepsy uh, change over time, because as we know, with the years, we have increased population of elderly people. So the first population-based study for new onset epilepsy showed that there is no change in the incidence of the earlier group, which is younger than 65 years old age group, but there is five-fold increase older than 65 years old population. So as you see here with the graphics, you can see the trend, and we can even divide these partial, focal, or generalized epilepsy. So they found that almost 1.5% of the population over 75 years old patient had active epilepsy. And about 25 of the prevalence cases had an identified cause, and 60% of them were found to have partial epilepsy rather than generalized epilepsy. Well, the prevalence and incidence, the studies are important with those population-based studies, because we need to find out the prevention for those individuals. Unfortunately, there's no prevention in the younger group, which is 65 years younger. If we take the cutoff point as 65, there's no prevention for those individuals. And in fact, obviously, no prevention for the elderly population. And if we add the cumulative increase by years, we really need to consider about this. It's very important. And there are a couple more studies that I can show, but one of them is from Denmark. They make the comparison with the global burden of disease prevalence. In 2018, they found the similar results with the global measures. Basically, they showed the similar thing. Epilepsy, new onset epilepsy increased after 50 years dramatically. And when they classified whether focal or generalized epilepsy, the focal epilepsy is going to be a little bit more than the generalized epilepsy. And when they divide into the gender for both idiopathic generalized and focal epilepsy, you will see the trend uh, uh, based on the gender with the male uh, difference, male preponderance compared to the females. With the idiopathic generalized epilepsy by age, we know that the first decade, the incidence is going to be getting higher and then gives the plateau for both female and male patients, and they're going to be similar at the end. They're not going to show that significant gender difference. As a summary, uh, uh, although these numbers are from 2010, among 1 million adults in the United States over 65 years of age, 1.8% of them had epilepsy. And the cumulative incidence of epilepsy through age 74 is going to be at least 3%. The greatest incidence in persons are going to be 75 years and older individuals. And 60 of them had the partial seizures, and two-thirds had no known etiology. However, the cerebrovascular disease are still the most culprit etiology in that group. And approximately, if you're talking about the unprovoked seizure risk in these elderly population, the Alzheimer disease and non-Alzheimer dementia, the sixfold in Alzheimer disease and eightfold in non-Alzheimer dementia. So there is a big comorbidities and associated disease, as a matter of fact. Therefore, there are lots of questions that we need to answer. One is, and the big one is aging brain, how we become more prone to epilepsy, and what can be done to increase the seizure threshold, and what would be the role of aging in hippocampus. So as I told before, uh, the elderly population is growing by time with the healthcare standards and all these other factors. I took this from U.S. Department of Commerce Census Bureau, and it shows the 2000 population distribution by the age, and 2010, and now 2020. You see how increased this elderly population by decades. So since we have a growing problem and we do not have clear prevention and explanation for these possibly distinct entity, epilepsy in elderly, how we diagnose that. So the diagnosis is extremely important, as you can imagine, as in other disease, but especially in this patient population is even more challenging or could be more challenging. uh, the accurate history of the onset and how it evolved and how it recovered from the incident is very important. So when we ask questions to the patients, we need to take the details because these details would give the essential suspicion for possible seizures in the elderly. So the usually unprovoked seizures are missing uh, because these distinct population may live alone. Even if they live in nursing homes, they may stay in their room for a long time during the day, and during the night they're alone. And the seizure semiology I'm going to talk about soon could be very hidden. So the history taking is extremely important. And identify etiology and the precipitants obviously is going to be another one that we need to list for these patients and do extensive testing if we need to. And then once we establish the diagnosis, then okay, are we going to start the medication? Which medication we're going to prefer, and how long we need to treat them? Those are the essential questions, obviously. So I just would like to talk about a little bit about differential diagnosis. So as with other paroxysmal events, there are maybe four major differential diagnoses for these paroxysmal events with altered mental status. Uh, could be unprovoked epileptic seizure, as we are talking about, or some provoked epileptic seizures, could be due to some metabolic toxic problems. Uh, these episodes could be non-epileptic, but physiological spells like syncopes, or these events could be just psychiatric spells. So the most common ones for the differential diagnosis are the syncopes, especially the convulsive syncopes, micturition syncopes, or the cough related syncopes, transial ischemic attacks, transial global amnesia, and migraine attacks, panic attack, sleep disorder, some behavioral or psychological issues that we've seen with certain neurodegenerative disease could be misleading, or obviously for any provoked seizures with the metabolic toxic disorders. So when uh, uh, when we think about these differential diagnoses, uh, as I try to say this, patients new onset epilepsy with elderly population may come with the confusion, delirium, and we should be very careful about these testing to find out if there's any electrolyte disturbances and any medication problems or any infectious, these things. And the patient may come with the dizziness with or without loss of consciousness or partially aware, uh, um, altered mental status. Uh, those, then we need to look at the cardiovascular problems, if there is any, or any acute neurological issues like cerebrovascular issues, or other metabolic issues or sleep disorders, and some behavioral issues if you're come across like abnormal movements, tremor, shaking, and then we need to look for the other possibilities underlying these behaviors. So as we said, the diagnosis is challenging, and uh, most of the most of the new onset elderly cases are secondary to cerebrovascular disease uh, and metabolic disturbances, dementia, traumatic brain injury, or drug therapy. I'm going to talk a little bit more about these things because they could be the factors that prepare for the epilepsy in elderly population. So another differential diagnosis is going to be, I said, psychogenic non-epileptic spasms. Just would like to say a couple notes about that. Psychogenic non-epileptic spasms are often misdiagnosed spasms, either way around. Sometimes they're under-diagnosed, sometimes they're over-diagnosed, uh, but because no single clinical feature is pathognomonic for psychogenic non-epileptic spasms. There are several studies, but none of them are really differentiative for epilepsy, epileptic seizure versus psychogenic seizure. However, the gold standard is video EEG monitoring, and the stereotypy is mostly helpful. Uh, and we know that 70% of the psychogenic spells develop between 20s and 40s, and at least 10% of them. In fact, some of the studies may show up to 30% of patients with and, uh, non-epileptic psychogenic spells may have epileptic seizures or had epileptic seizures and they acquire psychogenic non-epileptic spells as well. So we do see not uncommonly these two entities together. And majority of the patients with these non-epileptic spells, psychogenic non-epileptic spells, may have a history of developmental insults or trauma, which cause psychological stress that is too much than the individual can cope with that. There are two studies. I just would like to emphasize that in those elderly population, about 14% of them had psychogenic spells, but the non-epileptic, non-psychogenic spells are obviously higher. And the last one is a couple notes here that I found important, uh, uh, which is these patient population, psychogenic spells in elderly people. These individuals have actually relatively better emotional health compared to the younger ones. However, they may have the cognitive function could be worse because they may have physical health problems, they may have traumatic experiences, but when you come to the psychotherapy or emotional health status, elderly population showed better compared to the younger adults. So after this differential diagnosis, when I look through the literature and read more and more, I realized that well, we we kind of know that the epilepsy in elderly is likely a distinct entity. But how about the age cutoff? Because I described the elderly based on the ages and other variables. But when we say the elderly onset, the seizures are starting when? 65 years of age or 70? Or is there any uh, other pathogenesis behind it, that there is a transition period? Because these patient population represent a distinct entity. Their etiologies are different. Seizure characteristics are actually clearly different, and their comorbidities of the young onset epilepsies are uh, pretty different, clearly different. So this is an interesting study with the machine learning model. They classified the class variable by the age of onset. Some features uh, uh, was uh, uh, independent, was accepted as independent variables, and then with this machine learning, it's actually when they investigate this population, they found some specific clinical features, and based on these and how they uh, you know go how they go into the epilepsy, some clinical features could be clue for that, like the family history, etiology, semiology, as we pointed out, um, having the motor seizures, chronic medical conditions, abnormal examination, birth trauma, um, learning problems and learning disabilities or psychiatric problems, social habits, especially the recreational drugs use earlier than 65 years of age. They may prepare the patients uh, uh, to the elderly new onset epilepsy, perhaps. So I think when we try to make this uh, distinct group, the most striking and intriguing feature is the clinical semiology. It is really different than the younger patients with epilepsy and seizures, because in elderly population, uh, epileptic auras are less. Seizures manifestation is extremely subtle, and it you may just see the patient with the intermittent here and there confusional episodes, and usually these episodes can steady stay for several minutes, but they may not uh, evolve into a motor seizure, and their postictal phase could be much longer than we used to see in the younger epilepsy individuals. And another thing is uh, uh, expectedly, or maybe ironically, we do see patients to be hospitalized much higher uh, uh, than the same age individuals without epilepsy, because these actually prolonged confusional episodes may deteriorate their metabolic issues, their the alertness, and they may found on the street wandering. They might be in a very poor shape, and they hospitalized. And if we suspect, we can make the diagnosis. So we talk about that. This is just of any studies that you can find with the new onset epilepsy in elderly population, you will come across those symptomatology and semiology. And there is the studies show that the 75% of those individuals had temporal lobe seizures, and they were diagnosed in the EMU monitoring with the video EEG, long-term video EEG recordings. And we know all these clinical semiologies already. And I just put this slide because how subtle these episodes and the diagnosis could be challenging, as a matter of fact. From Harvard Medical School, the investigators published in 2017 two patients they took with 67 years old and 58 years old. They were diagnosed with Alzheimer's disease or the initial phase of the Alzheimer's disease based on the other clinical and histopathological testing. And they came with the confusion only. And but the suspicion rate was very high because they revealed paroxysmal intermittent spells of prolonged confusion, and then they come back in normal. And then with the time, these episodes get more frequent and longer. So they did a little bit more extensive EEG recording by using the Foramanawala electrodes. So then what they found epileptic abnormalities, interictal epileptic abnormalities in the hippocampal region without the scalp EEG correlate, and obviously EEG seizure at the same time. Is one of the patients showed from the left mesial temporal region, showed the EEG seizure activity, but the scalp EEG was totally normal. So they call it transient epileptic amnesia if you are very suspicious about that. They may start after 55 years old with these clinical presentation, and they could be very silent, and these individuals in terms of the seizures. So many with the EEG abnormalities, obviously the routine EEG, when we have the suspicion, could be the first test. However, based on the history, clinical presentation, we may go for the more extensive studies as long-term video EEG monitoring, basically. So there is a nice algorithm here, which was depicted by Cleveland Clinic colleagues with this, when we have the seizure suspected in elderly population, we can do some additional testing, as you can imagine, and then you will do some, after all these testing, then the patient needs to be referred to a neurologist and epileptologist. So, after talking with the seizure semiology and diagnosis, uh, I mentioned briefly about the partial seizures versus generalized epilepsy or generalized seizure, idiopathic generalized epilepsy or focal epilepsy. Uh, there are studies up there and show that idiopathic generalized epilepsy in adult onset is much rarer than the younger patient population, as we can estimate. And they found that they have actually more favorable prognosis, uh, uh, even though some of the patients may show an increased seizures in that age. So, uh, uh, there is one study, this retrospective study, a single center cohort study. They just looked at the late onset genetic generalized epilepsies. They found the median age 56 at the seizure onset, and they had generalized seizures, and few of them had the absence seizures, but they had uh, family history is one of the striking finding, and uh, these patients were mostly treated with Depakote valproic acid in 10 patients. Only two of them were uh, Keppra levetiracetam, and they all, 12 individuals we are talking about, they all had the good outcomes. Uh, I just would like to mention about uh, uh, status epilepticus, non-convulsive status epilepticus especially, and the mortality risk in this patient population. This is an interesting study. I just put it that because this investigation was done by the internal medicine physicians, not the neurologists, and they it comes from Spain. The internal medicine floor, they scan through the individuals, elderly individuals uh, who were admitted, and uh, and how uh, they and they how many of them had the non-convulsive status epilepticus, and what would be uh, uh, the distinct uh, semiology or the risk for mortality, how they uh, uh, continue, how was their how were their prognosis during the hospitalization. So this was an interesting study because mortality rate was found 37% in those patient population, which they found 54 individuals with non-convulsive status epilepticus. Basically, they diagnosed with the decreased consciousness, and they did the EEG, and they found the compatible finding with the clinical semiology and the EEG findings. So, but they said that, okay, main etiology, what they found in those patient population was the cerebrovascular disease is number one, and the second was the antibiotics. And then the metabolic issues. So non-convulsive status epilepticus is account for 20 to 30% of status epilepticus. We know that. But with the increased with the population incidences increased by age, and this global incidence is uh, likely increased, and with the comorbid disease, with the age, the mortality risk at least estimated by 22, uh, uh, and with this certain group likely much higher than that. So the mortality, we know that the SUDEP, sudden unexpected death of epilepsy, is related to epileptic seizures and also some other factors that the patient might have. And obviously, with this elderly group, it's easy to estimate that the SUDEP would be higher than the other groups. So when we talk about the idiopathogenesis, uh, there are, you know, main factors that we can talk about. I said cerebrovascular disease are number one in this group, obviously, and dementia would be another one, and also metabolic issues. But interestingly, some other social factors, which I briefly touch on that, like smoking, drug abuse, social habits, and these things are also important. So it's interesting studies I came across. There, there is a study shows that maybe the late onset seizures could be a predictor of subsequent stroke. So uh, many patients with unexplained seizures may have occult cerebrovascular incident, and which was actually showed in 1988. And they said, and they claimed the same thing, that sometimes onset of seizures in late life is associated with striking increase in the risk of stroke. So when cerebrovascular disease are number one, and the head traumas uh, and unknown ones are the big ones, and tumors, dementia, metabolic toxic, we already talked about that. I don't want to give too much detail about the pathogenesis, how it goes, but especially post-stroke epilepsy, which is the big uh, bulk in that patient population. We do see the post-stroke seizures either at the time of the stroke or after the stroke, and this after is it's about 7 days that is accepted. So, but they're uh, pathogenesis for the seizure occurrence or seizure evolution found to be different. So the acute seizures at the time of or early seizures at the time of the stroke could be due to some neuronal excitotoxicity with this abrupt change locally for integrity, blood-brain barrier, or some alteration in gene expression and ion channel dysfunction. Whereas when we talk about the late seizure, then we do see some epileptogenesis. So by saying that, we need to consider the synaptic plasticity, reorganization. Maybe it starts with chronic inflammation, gliosis, angiogenesis, neurodegenerations, sprouting, some selective neuronal loss, obviously altered synaptic plasticity. So, uh, uh, so these could be responsible for the neuro etiopathogenesis in these neuronal milieu. Uh, in another uh, uh, associated disease with that population is the neurodegenerative disease. So neurodegenerative disease has its own pathogenesis, and this pathogenesis actually play major role to generate seizure activity. We know that because uh, uh, I already showed in Alzheimer's disease, we do see late onset epilepsy sixfold, and uh, and several studies suggest that the cognitive decline and seizures may share common pathophysiologic mechanisms. And as in Alzheimer's disease, the other neurodegenerative disease more or less may share this kind of association, like Down syndrome and Parkinson disease as well. So just quick touch base. I just would like to mention about the neurovascular unit dysfunction as a mechanism of seizures and epilepsy during ages. So this etiopathogenesis is actually all about this neurovascular unit dysfunction, because this we are talking about the neurons and the vascular uh, uh, interaction, and uh, it involves uh, lots of pathways and uh, interaction, blood-brain barrier, uh, and uh, lots of uh, microstructural elements around the neurons, and the transition to uh, reciprocal transition between the capillary and the neuronal elements. So I think in the future we need to study our treatment modalities based on this. So let's talk about management. I don't want to exceed the time. So just quickly, we know that the elderly population is special population. So they have the reduced metabolism, clearance, decreased protein binding. So we have to study or check the free level if we need to, like phenytoin. This is important. And we try to avoid the enzyme inducers in those population, and we try to avoid the certain medication that are shown that potentiates the osteoporosis, and we should be very careful about the toxicity. So there is a good study here. It's a review article. They compare and they looked at the four randomized control studies for the lamotrigine and levetiracetam, carbamazepine, gabapentin, and they found that lamotrigine and levetiracetam were better tolerated. And you see these details of the studies. Patients with older than 60 years of age with epilepsy would have psychological issues, cognitive impairments. They may tend to be more depressed, anxious, and also fatigue. So we need to be considering these situations when we choose the certain anti-epileptic medication. So we try to avoid the drug-drug interactions, as I said, the enzyme inducers and all these things. I just would like to touch on briefly the nursing home patients, because these patient population is very important, and they're unfortunately very high risk of polypharmacy uh, and likely to be treated with older anti-epileptic medication, which is exactly true because I do see in my practice very much. Many patients, unfortunately, are on old generation drug like phenobarbital, phenytoin, all these things, and they're very they suffer lots of side effects. So these distinct population. So the epilepsy surgery, just couple sentences. Resective surgery is effective in every age. In elderly population, we need to be a little bit more careful. We need to, as we do other patients, as a matter of fact, we need to evaluate the patient individually in detail. So there are some, we need to uh, uh, understand the predictive factors for their postoperative prognosis. So this study is one of the nice one. It's 8 centers in France. They looked at the predictive factors after the epilepsy surgery in those patient population, and they found these MRI, neuropathologically confirmed hippocampal sclerosis, PET hypometabolism compatible, temporal lobe epilepsy as a whole, intracranial exploration need if there is no intracranial exploration is a better predictive factor, and postoperative number of AEDs is another one. The less is better, and even though they had the pretty good results, neurological adverse event rate is a little bit higher than the younger age population. Neuropsychological complications could be transient. And so this is a nice review how we need to approach for those patients uh, are potentially surgical candidates. So we need to be these patients obviously needs to be evaluated in our comprehensive epilepsy centers, and we need to you know, age is not a barrier. We talk about that, but comorbidities needs to be monitored, and try to avoid the intracranial monitoring. We try to uh, less invasive possible. And in that regard, the laser ablation, radiofrequency ablation, the new techniques are actually very important, and it's very beneficial for this group. So at the end, I think what I learned is in this patient population, the new onset epilepsy is increasing. And diagnostic challenges are there, but could be overcome by basics, meaning history taking, questioning, getting the answers, collateral information, and then if we really think that there is a high suspicion rate for epilepsy, then we need to do much more detailed investigation. Well, the new onset epilepsy is a distinct entity. I believe in that. And it's interesting if there is any possible transition which could start decades earlier. This is extremely important finding because we always, talk loud about we need to develop anti-epileptogenic disease-modifying agents to provide the prevention, secondary prevention, primary prevention. This is even much more important in this distinct group because these patients could be evaluated accordingly. Well, I think that's all I can tell in the time limit. Uh, I would like to thank you for everybody, and I would be happy to answer if there is any questions.
I don't see any questions in the chat. I do have a question though,
Sure.
Dr. Urbiat, in regards to, and I did see that you noted about falls, and just with the elderly, with the population aging and falls, are they looking at like more of a correlation with falls and triggering like new onset epilepsy? And I asked that just because I have my mother's 78, but it seems just because the population is getting older, we're living longer. Some of the factors made the brain is aging and that's triggering, but always looking at the risk of falls, as people, especially if they're living alone or if they're they're not on a one floor. So I was just curious. I did see falls mentioned, but I'm wondering if that's like a significant factor in just the increase in like early onset.
This is a very good question because the falls are considered under TBIs in most of the studies,
Okay.
and TBI is another risk factor, and it's a pretty big risk factor after cerebrovascular disease. So some of them revealed as intracranial hemorrhage or subdural hemorrhage or cortical hemosiderosis, which are the predisposing for seizures. So we don't know exactly what would be the mechanism after the TBI or cerebrovascular or the hemorrhagic incidence. That's why, in this population, the secondary prevention is important, not to develop the seizure afterwards.
Okay. I don't see any more questions in the chat. I do see some hearts floating around that were in your presentation. But if there aren't any more questions, we are going to conclude. Thank you for the presentation. That was great. We will be sending out a brief email survey after the conclusion of the seminar, so please look out for that. And additionally, I wanted to thank our sponsors again, SK Life Science and UCB. And just to make note of some Epilepsy Association's upcoming events, this is the last seminar of the year. So you can look back at the yearly that's going to be available on YouTube. And then we are currently working on next year's seminar schedule. I'm hoping for that to be posted by the end of this year. In addition, we have our last special event of the year. That is our 34th annual gala, which will be on November 7th at the Hilton Cleveland downtown. Dr. Urbiat will be presented with our Legacy Award. So we're really excited about that. And registration is available through our website. If you want to learn more, you can also contact Ethan Miller, our manager of development at EA, for further information. Thank you again for attending the seminar, and we hope to see you at future seminars. Have a great
Thank,
day, everybody. Thank you, Dr. Urbiot.
thank you, Ron. Thank you very much.